Discussion on atherogenic dyslipidemia and related topics. Atherogenic dyslipidemia is a triad of increased blood concentrations of small dense LDL, decreased HDL particles, and increased triglyceride-rich lipoproteins. Atherogenic dyslipidemia has been linked with coronary artery disease and cerebrovascular disease. Lipoprotein particles are measured using nuclear magnetic resonance spectroscopy. Though LDL cholesterol levels have a strong and consistent association with coronary artery disease and cerebrovascular disease, such association with peripheral arterial disease is not robust. It has been shown that NMR-derived measurement of LDL particles correlates with incident peripheral arterial disease. Assessing complete lipid atherogenic risk burden. Even though LDL cholesterol is currently taken as the important marker of atherogenic risk due to lipids, it is only a partial marker. Complete lipid atherogenic risk burden assessment should consider all other atherogenic cholesterol particles: lipoprotein little, intermediate density lipoprotein cholesterol, chylomicron remnants, and VLDL-C. Apolipoprotein B or ApoB is ideally suited for the direct measurement of all atherogenic lipoproteins together, since each atherogenic particle contains one ApoB100 molecule. Non-HDL-C, on the other hand, quantifies total atherogenic burden by measuring the total amount of cholesterol in all atherogenic particles taken together. Non-HDL cholesterol is equal to total cholesterol minus HDL cholesterol. It can be obtained in the non-fasting state without affecting the results, as the components affected by a meal do not come in the equation. Non-HDL cholesterol is a secondary target of therapy as per guidelines. Non-HDL cholesterol has been shown to be an independent predictor of coronary artery disease regardless of triglyceride levels. But LDL cholesterol loses its predictive value with triglyceride values above 400 milligrams per deciliter. High quality plant protein sources, legumes, soy, nuts, improve lipid profile. Meta-analysis published in Circulation evaluated randomized controlled trials comparing red meat consumption with other diets regarding cardiovascular risk factors. One of the key findings of the meta-analysis was that high-quality plant protein sources like legumes, soy and nuts resulted in more favorable changes in total and LDL cholesterol in comparison with red meat. So far, though epidemiological studies suggested that higher red meat consumption can lead to higher risk of diabetes mellitus and cardiovascular disease, data from randomized controlled trials were inconsistent. Hence, the importance of the outcome of this meta-analysis of randomized controlled trials on this aspect. Extreme high HDL cholesterol may paradoxically increase risk. Usually, HDL cholesterol concentrations are inversely associated with cardiovascular disease and mortality. But there is some data to suggest that extremely high HDL cholesterol might increase cardiovascular risk, that is, an occurrence of a U-curve relationship. Madsen and associates checked this out in two prospective cohort studies, Copenhagen City Heart Study and the Copenhagen General Population Study, including a total of 52,268 males and 64,240 females. During a 745,452 person years of follow-up, they could demonstrate a U-curve relationship of HDL cholesterol with higher mortality at both extremes in both men and women. The HDL level with lowest all-cause mortality was 73 milligrams per deciliter in males and 93 milligrams per deciliter in females. At the other extreme, a hazard ratio of 2.06 for all-cause mortality was noted in men with HDL cholesterol level of 116 milligrams per deciliter or more. In women, A hazard ratio of 1.68 for all-cause mortality was noted with HDL cholesterol levels of 135 mg per deciliter or more. It is possible that genetic mutations leading to high HDL cholesterol also confer adverse cardiovascular risk. An alternate possibility is that extremely high HDL cholesterol levels are due to a dysfunctional form. It has been noted that loss of function mutations of SCARB1 gene encoding the major transporter of HDL cholesterol, which delivers it to liver for excretion, results in marked increases in HDL cholesterol level as well as paradoxically increased risk of coronary artery disease.